ensuring access, affordability, and quality through PMJAY. The last 2 days have seen various panel discussions on different aspects of PMJAY. This session is envisioned as the meeting point of all our discussions over the last 2 days and promises to touch upon very important aspects such as increasing beneficiary coverage and awareness, ensuring continuum of care, integrating digital health infrastructure laid down in ABDM with the PMJAY scheme, and the options that will facilitate the holistic healthcare provisions to beneficiaries across primary, secondary, and tertiary care. Without further ado, it is my honor to introduce today's panel. We welcome our chairperson, Dr. V.K. Paul, a globally recognized medical scientist and public health exponent. He currently serves as member Niti Aayog, where he leads the health, nutrition, and HRD verticals. We have our first panelist on stage who needs no introduction, Dr. R.S. Sharma, CEO, National Health Authority.
It has been a very learning experience.
I would also like to welcome on stage Dr. Sunman, who has over 30 years of work experience in universal health coverage, health finance systems, and health policy. He currently serves as professor and former dean of Seoul National University, South Korea. Our next panelist for today's session is Dr. Nicholas Goodwin, with over 20 years of work experience in development projects, largely focusing on behavioral interventions. He currently serves as Asia Pacific Director, International Programs, Behavioral Insights Team, UK. Joining us virtually, we have Mr. Santosh Mathew, a retired member of the Indian Administrative Services, batch of 1985. In his illustrious career, he has worked across government departments at the national, state, and state level, and currently serves as country lead, Social and Public Finance Policy, Bill and Melinda Gates Foundation. Lastly, joining us virtually, we have Dr. Vipul Agarwal, who is a member of the Indian Police Services, batch of 2000 work, with extensive work experience in the Gujarat State Health Department and former Deputy CEO of National Health Authority. Finally, I'd like to extend a warm welcome to our moderator for this panel, Dr. Nishant Jain, a thought leader in the field of health systems, health finance, and health insurance from the past 17 years, who has been a very esteemed senior advisor to NHA for the Ayushman Bharat PMJAY scheme. He currently serves as health specialist for Asian Development Bank in the Human and Social Development Division. I would like to now hand over the stage to our moderator, Dr. Nishant Jain, to open discussions.
Thank you, and a warm welcome to everybody. And I'm very privileged to be part of this panel where we have some very distinguished speaker. And this is a very important panel because we are thinking ahead. Till this time, we were looking at what has happened in the past. Now, this session tries to see ahead. And I think it is very looking to look ahead, not only for next 3 months, 6 months, 1 year, but even much beyond for many 5, 10 years, because that's where we want to go, which direction we want to take. And there could be nobody better than Dr. V.K. Paul to set the context, because he is the person who was one of the force behind the PMJAY when it was approved, when it started. And I remember sitting with him and discussing with him how we should do, what should happen. And I think that we are very lucky that he is here and he has agreed to chair the session. So Dr. Paul, over to you.
Thank you very much. Good afternoon, distinguished panelists on the dais, distinguished colleagues, participants, guests, friends. This session will focus on ensuring access, affordability, and quality in healthcare through PMJAY. I think this is the most important session, not because we are on this side, but indeed it has several, key words in the list of objectives that has been shared with the panelists. It's going to talk about increasing coverage, increasing beneficiary awareness, refining technology in use, improving quality of care, taking care of the missing middle, integrating digital health and technology, ABDM and PMJAY coming together, and so on and so forth. So I would really, I'm really anticipating a great discussion, and we have a wonderful moderator who has such a deep national and global experience in universal health coverage paradigm and made significant contribution to the structure and to the essence and the implementation plans of PMJAY. So looking forward to learning. Nishant, over to you, and of course I'll be happy to sum up toward me. Thank you.
Thank you, sir. And so now we have the first speaker who will set the context. is Dr. Sunman from South Korea. And of course, you got the introduction, but just from my personal experience, I can say he's one of the most distinguished expert in this field and also a great human being. And he has vivid experience from across the places to work on with various organizations, has worked from the other side of the table where he was sitting with the government, from the other side where he was sitting in the university. So he has seen both the sides, and I'm very happy that he's here to set the context for us and also suggest his thoughts on what can be done. Thank you so much.
Thanks a lot. Thanks a lot. It's my great honor to join this meeting and share the experience of Korea, both good lessons and negative lessons that can have some policy implications to India. I'm an academia and I'm a health economist by training, but I have some experience of outside world. Actually, I recently came back to my university office 2 weeks ago after working as the president of a government agency under the Ministry of Health and Welfare. So, brief history about population coverage. We started covering, it's different from Indian context. It is quite good for India to start covering the poor and vulnerable. But in the case of Korea, we started covering the employees in large corporations. And then at the last minute, we covered the rural population and urban population. And employees are covered based on their employment, so firm-based sickness fund. And for the self-employed, they are based on the region they live. So in terms of the facilitating factors, it's not just from Korea, but if you look at the global experience, that all major policymaking, the drivers of policymaking is politics. Okay? So especially if you have a national health insurance, it should be a mandatory enrollment. And in Korea, it was enforced by the authoritarian political regime. And also, economic growth matters because for the government to be able to support some subsidy, and also people have the capacity to pay. And as you know, the important challenge comes from how to fill the missing middle, the self-employed. There is no secret. Like NHA or PMJAY, it's a full subsidy for the poor, but in the case of Korea, it's less than 5% of the population. So the key challenge is coming from how to cover the informal sector and the self-employed. Again, there is no secret. It's government subsidy. But in the case of Korea, there is no full subsidy but partial subsidy. It started with about 50% subsidy for the self-employed. And then incrementally, the amount of subsidy declines. But these days, almost no subsidy for the self-employed. But at the beginning, subsidy is the key thing. And also another important factor is family-based membership. I'm not talking about the poor and vulnerable. Even for the self-employed, even for the employee in the formal sector, if you adopt a family-based membership, you can much more rapidly increase the population coverage. So if you're serious about to extend the population coverage above the poor and vulnerable, like a current NHA, then you should also consider this family-based membership. In terms of pooling, Korea started with the multiple pools, 3 different categories, and with more than 300 sickness funds. And then we merged all of them into one about more than 20 years ago. Because before the merger, we have multiple pools, and different pools have different fiscal capacity. So most of the sickness fund in the rural areas, they suffer from fiscal crisis. So government used a risk adjustment across pooling. It's similar to the intergovernmental transfer mechanism in the public finance. But even with this type of risk adjustment does not work to rescue many sickness funds from the fiscal crisis. So we merged all of them into one in the year 2000. At that time, again, the government was a very progressive government, very keen to equity by merging all of these plans into one. But even before the merger, we have a very favorable conditions such as uniform statutory benefit packages across schemes. Of course, some schemes they can provide more generous benefits, but statutory benefit package is the same, similar to NHA. Each state, they should provide basic ones, but they can provide more generous if you want. And we have a uniform payment mechanisms, and even before the merger, we have a uniform single agency to work on the claim review and assessment. So thanks to this type of some factors, I think we could achieve the uniform merger of all insurance societies one-to-one. In the context of India, I'm not sure whether this type of a big single pool works or necessary, because it's not just you are like multiple countries, right? It's a big country. So, but at least state level, I support at the state level uniform single pool covering not only the poor and vulnerable, but also employees or formal sector workers might be beneficial in terms of efficiency and equity. Insurance organization, we have again single pool, National Health Insurance Service, but starting about 10 years ago, this insurance agency collects all contributions for all social insurance schemes to enjoy the economy of scale or economy of scope in the premium collection. So this agency collects premiums from not only for health insurance, but also for pension, unemployment insurance, workplace injury. And then it distributes the contributions to different insurance schemes. But there are two insurance agencies in terms of the functions, because in Korea still premium collection is important. So premium collection and payment are done by National Health Insurance Service, major insurance agency. It employs about more than 10,000, more than 13,000 employees. But we have another specialization agency, HERA, because the main function of this HERA is a claim review and assessment. And because current NHA does not work on the premium collection, probably HERA's function can give a lot of lessons for NHA. But if you want to extend the population coverage and engage in a premium collection to cover the entire population, then your function, the insurance function, should go beyond the HERA. Policymaking, we have a so-called tripartite committee system, because national health insurance is not just a simple healthcare sector's problem. So all the major decisions on premium collection, premium contribution, pricing, benefit packages are decided by a tripartite committee. So 8 members from payers, 8 members from providers, and 8 members from public interest. And the membership of each membership is provided not to the individual, but to the representative organization, with the exception of these 4 independent experts, like me. So I served this committee for a long time. And then we have another committee. It's called Long-Term Care Insurance Policy Committee, because we have another new kind of insurance mechanism for long-term care. So we have a similar policy committee for this long-term care insurance policy committee. I'm now serving this committee. Purchasing, as you know, purchasing power of health insurance is important. And for that, role of state budget is very low, even for public hospitals. The majority of the revenue of public hospitals, they really depend on the reimbursement from health insurance agency. But also, if you're serious about this purchasing power, you need to expand the population coverage. And HERA plays a very important role in quality evaluations based on the review and assessment of medical claims, and also public disclosure of provider performance. This is a way to reduce information asymmetry and help consumers to wisely choose providers based on the performance. And we have a pay for performance for some selected areas and some minimum type of the drug utilization review system. But please do not overestimate the impact of these initiatives, because still the majority of the hospitals are private. More than 90% of the hospitals are private, and they are paid by fee-for-service. So why Korea has a very sophisticated this type of system? First, my answer is that we have to. Private, predominantly private, fee-for-service, without this too sophisticated system, we cannot handle them. So we have to. Another one, if you have a more aggregated payment system like a case-based payment, you may not need this type of sophisticated review system. Again, as an economist, I can question, is it effective? Is it cost-effective? Maybe or maybe not, because the increase in healthcare expenditure over the last 10 years is the highest in Korea among all OECD countries. Okay? So this simple mechanism may not be enough. And also there is a session on health technology assessment yesterday, and we all know that we need a good kind of economic evaluation mechanism, cost effectiveness or cost utility analysis, but again, that's not enough. Because how to cover, whether we should cover an anti-cancer medicine that costs like $1 million per year per person. We need a judgment. We need a transparent process. And in that case, we are experimenting some kind of citizen participation, like a, in the UK system. So we are trying to incorporate what's the public value, what's the public attitude toward this type of very expensive, cancer medicines coverage. So we need a good combination of scientific approach plus value judgment by citizen participation. So we need evidence, but that is not enough. We also need a good value system, value judgment system. More about challenges. I already mentioned the problems of service provisions in Korea, mainly because it's a private sector dominated system, fee-for-service. DRG is still covering only 8 categories of disease. Why? It's a serious oppositions by private providers. There's a huge demand inducement. And another aspect of private dominated delivery is a fragmentation and issues of continuity of care. Primary care is fighting with the big outpatient clinic, polyclinic in tertiary care hospitals. And also private sector, there's a strong opposition to payment system reform. And as a result of the dominance of big general hospitals, we are neglecting primary care and over-specialization. We are struggling with this primary care. So please try your best to strengthen the primary care and work hard to improve the continuity of care. We are struggling with this continuity of care in primary, secondary, tertiary care now, but even now and the future, another bigger challenge is the coordination between medical care and elderly care. See? So, financial protection. Well, government worked very hard to rapidly expanding the benefits packages, but the main problem is these private providers, they keep providing new services, which is not already in the benefit packages, because these uncovered services are not subject to price regulation, so it's a full pricing in the market. So it's much more profitable for private hospitals. And government introduced various protection mechanisms, like discounted payment for elderly and children, and reduced co-payment for serious disease, and also ceiling on the out-of-pocket payment. But still, the efficiency and equity of this type of patchwork and cocktail-based approach, whether works or not, is still, we are struggling. So financial protection is not just expanding the benefit package, but also you should regulate the provider behavior. Because provider behavior, they are willing to produce more and more of those unregulated, uninsured services. Example, about 75% of prostate cancer surgery is done by robot surgery in Korea. 75% of prostate cancer surgery. Contribution setting, as you know, social insurance is based on the wage income in principle. But nowadays, people have diversified sources of income. So if your contribution is only based on wage, it's not equitable. So Korea, we already decided to charge contribution based on all types of income. In other words, I pay contribution based on my salary from my university, but I also pay contribution based on my financial income, investment income. I think that's more equitable, but you should overcome some potential oppositions by the better off. And during this pandemic crisis, and also from the perspective of population aging, there's an increasing role of taxation, okay? So you should also take into account what is the optimal balance between tax financing and contribution-based financing. Rapid aging of population, this is a really, really big challenge. Okay? Increasing life expectancy, and at the same time, rapid decline in fertility. So Korea introduced a separate social insurance for long-term care, covering the elderly care. It's covering slightly over 10% of the all the population. But still, our main challenge here is that we are struggling with the balance between institutional care and home-based, community-based care. And also coordination between the health insurance and long-term care insurance is another challenge, because medical care is covered by health insurance, but aged care is covered by long-term care insurance. There are a lot gray area between them, and if those two services are covered by different schemes, sometimes coordination faces many challenges. So as I mentioned, again, we have a tripartite committee. The reason that I arrived in Delhi very late is that we have this year's last long-term care policy committee on Friday night. We have 6 hours of marathon committee meeting. It's national committee, it's tripartite, and providers, provider representatives, they shade their hair. That's the one way of opposition. So providers, they are complaining about the fee cuts. So after 6 hours of marathon discussions, 10 minutes before midnight on Friday, we get a final resolution. I was the chair of the committee, and a really terrible struggle. So that's why I came to Delhi a bit late, because I should really handle those national committee on Friday night. Thanks so much.
Thanks, Sunman, because, from far, Korea looks very attractive in health insurance, and there are a lot of good things. But at the same time, as you mentioned, there are a lot of challenges, and we should learn from them and also then try to leapfrog some of them, because we should not make the same mistakes. We should make new mistakes, maybe. So with this, I will go to Dr. R.S. Sharma, who is CEO of NHA. But I think more than CEO of NHA, he is a doyen in his field. And somebody who is at the helm of things at NHA, seeing the vision where NHA can go, where PMJAY can go and ABDM can work together. I think, sir, your guidance will be very important for us. Thank you.
Well, thank you, Dr. Nishant, and thank you very much, friends. Good afternoon to all of you. Dr. Paul. Just after hearing Dr. Kwon from Korea, I think we are pretty young in terms of experiences, if you look at it. We just started 4 years back, and Korea has had an experience of quite some time now. And I think the kind of, it appears from his presentation that it's a fairly complicated issue. It's not such a simple binary kind of stuff where yes and no type. It has a lot of complications, and these complications also are quite specific to how the demography is sort of distributed and stuff like that. So I think we have had this 4 years of experience, and I'd like to just, from the basis of that, I would like to just point out some issues which we think will help in increasing the efficiency, affordability, accessibility, quality of the healthcare, which NHA is actually responsible for in delivering in the PMJAY. So one is, overall, I feel that there are a couple of stakeholders. One is, the most important stakeholder is the patient. So what do we do for him? So one is that we find the awareness part of the patient is one issue which we have to deal with very specifically, because many times, because they belong to the poor strata of society, and when they go to the hospital guy says, where is your, he says, I have an Ayushman beneficiary, where is your card, where is your name? And unfortunately, because this particular list which has been given to us, 2011 SECC, this list has certain inherent deficiencies, because of which we have been searching for the beneficiaries in some sense. This is one program which is searching for its beneficiaries. That problem, fortunately, our Honorable Minister, Dr. Mansukh Mandviya, he has solved that problem by saying that, look, let's not look at SECC, let's look at what the states are doing, and let us learn from these states. Let's ask the states to provide the number of families equal to SECC if they are not able to find out the SECC families. And that's actually a very good solution which we have now got. And that has facilitated us. And basically what we want to do is to increase the awareness, to make every beneficiary feel entitled. And how that entitlement will come? That entitlement will come if the beneficiary has some token to prove that yes, he is a Ayushman Bharat beneficiary. And that's why we have undertaken a very massive program of generating PVC cards, which don't cost much, about 10 rupees or 12 rupees or 15 rupees, to each beneficiary, so that they have the card in their pocket, and as and when they fall sick, and as and when they need hospitalization, they should be able to go. We can't have a general awareness campaign, because general awareness campaign will mean that everybody will start looking for his data and it's not available, and then they will go disappointed, saying that it's not for everybody because it's for a specific group of people, and therefore the best way to make them aware is to provide them that token of empowerment. So that's one part which we are doing from the beneficiary side. Another is that when the beneficiary goes to the hospital, he must feel welcome. Somebody should guide him, otherwise the fellow feels lost. A villager who comes to the hospital, especially AIMS or anything, he just doesn't know where to go. So that concept of beneficiary facilitation agency, which many states have started operating and which are yielding very good results in the public hospitals, so that those persons are taken care of, they are identified, and then thereafter they are guided properly to get the treatment. So that's from the beneficiary side. From the hospital side, we are ensuring that we empanel hospitals, as many hospitals as possible. And that empanelment has been increasing, and now we have today 28,000 hospitals. We are also guiding them as to how they should file the claims of insurance, claims of reimbursement, because this claim filing is also purely digital in our case, and therefore they have to sort of go to the portal and figure out what kind of reports to upload, and there are many things which they have to be done, and that's the capacity building of these hospitals is something which is getting our attention lately quite enormously. So that's one part which we are doing. Thirdly, what is important is that while the hospitals, the provider side, they are also having this issue of rates. They always complain that the rates are low. Though of course we always tell them that, friends, you are getting such a large number of customers, the patients, and therefore there is always somebody who buys things wholesale, he always gets a discount. So you should not really look for the actual market rates, but maybe a little less than that market rate, and that's where we peg our rates also. But then for that matter, we have created a very robust mechanism of updating these rates frequently as and when the occasion arises. And so that's one part. We have also been expanding the coverage in terms of the packages. That's another part. We have been standardizing the packages using the SNOBAD CT codes and all that. So that's another issue which basically will ensure that the package is uniquely identified and actually is operated upon, and then that's the rate which is paid for that package. So that part we have been trying to systematize. The third issue is that because we have a digital payment, workflow system, what we call transaction management system. Now this system has to be very, very robust because it is actually catering for as much as 1 million claims processing per month. We have about 35,000 hospital admissions throughout the country under the Ayushman Bharat PMJAY, and of course this is being run with the help of the state government. The state governments are the major implementers of this scheme, and in fact many states are doing much more in terms of beneficiary financing, number of beneficiaries than what we have done, and all those beneficiaries are on this platform. So therefore we are processing large number of claims. Now obviously to process such claims which are not such just a financial payment part, no. These are reports, diagnostic reports, these are discharge slips, these are initial diagnostic. So all these things are a fairly complicated set of documents, and these documents have to be processed in a manner which is processed. They are on digital platform, but they have to be looked at it from the perspective by the human beings, because unfortunately they are not machine readable documents. They are PDF files, or they are some other kinds of paper written documents, the pen written. So until we come to that stage where we have the automatic adjudication, where we have the machine readable document, till that point we will have to do a manual process of checking and clearing these bills. And that is being done with the help of the state governments. So what we are doing is we are making this particular pipeline absolutely robust. It is also required because now that we have a digital platform, there are many schemes of the government of India as also the state governments which are now leveraging this platform. So for example, we are having CGHS for retired employees is on this platform. Similarly, we have a number of other schemes. Recently, we had the transgender scheme coming onto this platform. So there are about half a dozen schemes which are coming, and many are waiting to come on this platform. But essentially, unless this platform becomes very, very robust, versatile to handle all these different rates, different eligibility criteria, different caps, different those wallet sizes, we will not be able to run this platform. So therefore, what we are doing is we are developing and completely changing this platform, overhauling this platform, what we call platform version 2.0. And that is, fortunately, by the end of next month, everything will come onto this platform. We are in the process of migrating to what we call TMS 2.0. So that's another part. And of course, it will have all the modern, things of a modern technology platform. And it will be scalable, it will be inclusive, it will be standard-based, it will basically be able to leverage other things. And the heart of this platform is going to be a component called Health Claims Exchange, the one which was launched yesterday by our Honorable Minister. And the idea of a health claim exchange is that it is basically on the one side, it will get the providers' bills, and on the other side, the payers will be able to get access to those bills or those claims. And that will be coming into a format which is the FHIR compliant, which is basically standard-based format, which will have all the attributes so that it can be even done, auto adjudication can also be performed. So that's a platform which we are building, and we are building it as a digital public good. The first client of this platform will be obviously PMJAY, because this is what we have developed, but thereafter it will be open, and it is already open in the sense that it is already on the sandbox of NHA, where private players are actually experimenting, the insurers are experimenting, the providers are experimenting to essentially connect with this platform, play with this platform. So that is going to be a very robust platform which will be able to take the load, as much load as it comes. We have no problems of scalability. So that will definitely happen. Convergence will also bring about efficiency in the PMJAY, both in terms of the scale, because now we will have many more patients going to the hospital. So we will have better bargaining power, because if CGHS is also going, PMJAY is also going, ESIC is also going, then of course the hospitals will be forced to give us better rates, better facilities, better care for our patients. So I think this is going to support each other. This is, I think, what is going to happen, and we feel that we should be able to improve the performance very substantially with these steps. Last thing which I want to say was that apparently there is no connection between the ABDM and the PMJAY on the face of it. But actually, come to think of it, ABDM and PMJAY is absolutely connected, because they deal with the same individual, they deal with the same human being. And therefore, they will bring about continuum of care. Once you have a common identifier in both the primary and the secondary health segment, then continuum of care will happen. Once you have identifier, then all kinds of duplications will go away. There are people, we have found out cases where they are getting PMJAY, they are also getting the CGHS, they are also getting some other schemes. So they are doing multiple dippings. PM's dialysis program is also being, sort of accessed by them, and PMJAY is also accessed by them. But once you have a common identifier, this problem will definitely go away. And these are the connections which ABDM has got with PMJAY, and I think both these programs, they will work in synergy. And what we are doing is, we are also creating a number of digital public goods in the ABDM space also, which will actually make both these programs absolutely convergent. One area which I think, I'm sure Dr. Paul is fully familiar with, is the area of missing middle, which we have been working for a long time. Unfortunately, we have not been able to reach any conclusion, and I think that's a very substantial part of population, 30%. They are not so poor as to get a free medical, like PMJAY, but they are also not so rich so as to get an insurance cover of 30,000 or 40,000 rupees per annum. So that's where this whole trick lies, and I think that's where we are a little bit uncertain as to how to go about it, and guidance from the Niti Aayog Niti Aayog has apparently formed a committee to look into that aspect, and once we have their recommendations, we'll be able to proceed forward. But I think otherwise I don't see many challenges in implementation of PMJY. We will continue to improve the system, both from a technology standpoint and also from the other extension standpoint, and our states are working very hard. I mean, I have seen people with so much of commitment in the state governments that I feel really inspired by their passion and commitment, and they are fully committed to serve the poor people of this country. Thank you very much.
Thank you, sir. And I think you outlined very clearly what all steps are being taken, what are being thought of, and what could be done in future also. So I think coming from you, I think people must be assured that there is a strategic thinking going on in terms of improving the implementation. Now I'll come to Mr. Santosh Mathew. I'm very happy that he's able to join us, even though he's not in the country right now, but he's able to join us, and he has been on both the sides. He was a civil servant, but now he's on the other side. And so he has seen that what happens, what kind of constraint can any scheme face, and PMJY is no exception. Within a government system constraint, but what kind of innovations can happen to actually take care of some of those. So I request you, Santoshji, just share your thought process on what could be the issues which PMJY can tackle to improve for the future, and especially if there's anything on financing part. Thank you.
Thank you. I'd just like to start by congratulating the National Health Authority under the leadership of Arogya sir for the enormous progress that has been achieved in such a short time of 4 years for PMJY and 1 year for ABDM. 19 crore Ayushman cards generated, 45,000 crore worth of treatments in such a short time is no mean achievement. My few suggestions that I have to offer are in terms of what more can we do, and I have actually 4 buckets in which I would like to offer some suggestions. But I think I will restrict to 2 in this, and if I get a second round, I can come back. But if there is time, and I look to you to see whether I can go. First is, how do we reduce the friction in the journey of a care seeker? Like the Honorable Minister had said, अगर हमारा केंद्र बिंदु वो care seeker है, how can he actually navigate the system? Rest assured that there will be no denial of service. Rest assured that quality will be maintained. Now, why do I say denial of service? These are poor and vulnerable people. First of all, there is this whole issue of am I eligible or not? So the card will ultimately solve it. But the day-to-day navigation, imagine a 70-year-old woman, Bastar mein hai, mobile phone hai nahi, unpad hai. She should be able to call a toll-free number and say, beta, mujhe bahut sir dard ho raha hai, I'm having a headache. And it is not about what she is eligible for. We already have a call center that is operated by the National Health Authority, the state governments are operating, NHM is actually operating. So irrespective of what she is eligible for, if there is a triaging center which is able to listen to these complaints and actually do an initial triaging. Why is triaging important? They're important for 2 reasons. One is the creation of an electronic medical record and the population of their electronic medical record using a symptom checker. Today, there are a number of offerings in the market which by using an adaptive question tree is able to actually populate the electronic medical record. So when the doctor and the patient meets, the doctor actually has got almost 95 to 98% of the problems of the patient already captured. So no need of medical transcription, no need of major typing by the doctor, no need for data entry operator, and most importantly, a science-based recording of the symptom is actually, I'm not talking about clinical decision support system here, of course that would be beneficial, but that is the second order of magnitude. The second reason why a triaging station is the first point of call irrespective of schemes, and this can be achieved because today whether it is the health and wellness center, whether it is our primary, secondary or tertiary, or whether it is screening for non-communicable diseases, because ABDM, its standards, its registries, the ABA number, all of this is coming together. The penetration of our mobile networks, the willingness of our people to engage in digital ways of solving for their problems. This old 70-year-old woman I talked of may not have a mobile phone, but she's quite open to borrowing a neighbor's phone, calling with the assistance of somebody to a call center. But if we could make this an integrated call center, where all aspects of the health system, irrespective whether it's PMJAY, whether it is state care, whether it is an All-India Institute of the State servicing, but from there, if the electronic medical records journey could begin, when it is being created for the first time or with a subsequent iteration, this is something that I will urge government to kindly consider. The second point that I want to make regarding the electronic medical record is the fact that it is going to take some time before this becomes ubiquitous. But can the National Health Authority think in terms of offering some incentive or giving a pathway which says that you have already got this classification of empaneled healthcare providers, but those that are operating an ABDM compliant electronic medical record could actually be given a preferential pathway, and maybe 6 months, 1 year from now, a guillotine could be actually applied, that within this period, if you are unable to process via electronic medical record for all patients, then ABDM financing would actually, or reimbursements would not be possible. But here I would urge us to think not only of ABDM, of PMJAY, but also integration with our ESIS system. Just imagine, 500 million people through PMJAY, 400 million people through ESIS, that's already 900 million of our population. With extensive digitization, it should be possible for a single port of call and subsequent navigation by the system. But if this has to work, we need a denial of service hotline. Not a grievance that is processed with latency, but a denial of service hotline that is the ability to escalate. So not only are you giving options for care seekers to exercise informed choice as to where is the facility that she requires is available, what are the quality parameters that these different empaneled healthcare providers are actually demonstrating, but also the facilitation to navigate through this. If we can achieve, then the friction in patient journey would be a big step that is very easily solvable because ABDM is there with us. The second point that I want to raise is the quality of care. When we talk of quality of care, we can of course wait till such time that our electronic medical records become more ubiquitous. But when the claim processing is actually done inside PMJAY today, we have today millions of claims that are inside our system. We can actually develop a statistical sampling method through which these claims are actually analyzed and assessed for the quality of processes, the prescriptions, the follow-up, readmission rates. There are a number of things that actually can already be done using a phygital system, which is half physical, half. So expert committees could actually do this. And through this, you can have an internal gradation of empaneled healthcare providers rather than depending only on a NABH sort of accreditation, which, as you know, is measuring for proxies of quality and not actual quality, like what is the accuracy of case sheet capture, what is the accuracy of diagnosis, what is the treatment outcome, what is the adherence to standard treatment guidelines, how parsimonious and appropriate were the tests that were prescribed. These are all things that expert groups can actually assess even through a sampling methodology with all the data that the PMJAY system in the states already have. The other two things that I wanted to talk about was the question of payment to empaneled healthcare providers and fund flow to states. I'll just briefly mention, and I will detail it much later if there is another opportunity. And that is the transaction management system 2.0 is going to clean up the system substantially. But there will still remain something what I call a decision to pay. And this decision to pay is the coming together of number of people who are providing certifications. But today, the individuals who are doing the certifications, and ultimately the file goes to, typically in a SHA, it would be the CEO or somebody authorized by the CEO to then finally authorize payments. I would urge the NHA to consider running a pilot, particularly for government hospitals. Can we think of a system by which the locus of responsibility, the locus of accountability is much sharper, and using the TMS we are able to pinpoint those people whose wrong certification led to a wrong payment. But this would mean allowing payments to happen without the final sign-off by the CEO, which means making individual certifiers literally naked in front of our accountability systems without the cover provided by somebody else saying that I am authorizing systems. As a government pensioner, I get my payment, my pension on the 30th of the month. The data point that determines my payment for the month is my life certificate, is it in the system? It is not that somebody is going and approving my pension every month. Similarly, can we run an experiment by which individual certifications result in a payout without somebody having to finally sign and say, okay, I'm authorizing payment? Run this as a pilot to see how this is faring. And I remember R. Sharma sir saying on an earlier occasion, these are providers with whom you have long-term relationships. Even if you indulge or if your decision-making system results in an excess payment in this transaction, there is nothing stopping us from actually adjusting in the net. So because this is a multiple iteration mechanism. And finally, the point I want to raise, and I will stop here, is to adopt a just-in-time fund release system to states. You have the single nodal account today that the finance ministry has imposed. Can we think of like MGNREGS, that states are given 2 to 3 days worth of float, and as they draw down the money and the payments they make every day, can we actually automatically release money from the NHA pool to the state health authority, so that the issue of utilization certificates, the issue of some states having more money and others completely drying up, is actually sorted out through a just-in-time funding. Thank you very much.
Thank you. Thank you, Santoshji, for elucidating these 4 points. And I think these are very important, and it has a lot of implications in terms of maybe easing out the processes, building the confidence, but at the same time, we also see how it can be implemented in a transparent way. So I think, thank you for sharing it. I'll come to Nick now, because Nick is working on a very interesting area, which is, how do you actually make things happen by nudging them slowly? That is something which he's working on. And it's an experiment which was started by UK government, and there they basically set up this business intelligence unit, where now it's a separate company, in fact, and they try to nudge decisions, and they had found a lot of success in UK, and many other countries have followed some similar systems. NHA has set up a nudge unit under the guidance of the CEO, where I think this is the first health insurance agency in the world, maybe, which has a separate nudge unit within the institution. So Nick, maybe I'll request you to share in 5-7 minutes something on what can be done and what we can learn. Thank you.
Right. Thank you, Nishant, and thank you, Dr. Sharma, Dr. Paul, and thank you everyone for coming and sharing your experiences over the last 2 days. So my name is Nick Goodwin. I'm the Asia Pacific Director for International Programs for the Behavioural Insights team. We're an agency that's based in the UK. We have offices across the Asia Pacific region, and I'm very pleased to say that we're planning to open an office here in India in the next 6 or 9 months, so we hope to work with you all. As Nishant said, we've been lucky enough to be working with the NHA on improving access and utilization of the PMJAY program, and I'm really happy to have been able to do that because we've learned a lot about how you do that at scale. And I think what you're doing here in India, what the NHA is doing here in India, is providing valuable lessons for many governments, many agencies across the world, in terms of how you do this at scale and with great complexity of operating environment. So simply put, the work of BIT is based on one fundamental assumption, which is that behind every public policy issue lies human behavior. Whether you're working on tax, whether you're working on health insurance, whether you're working on COVID vaccines, behind all of those issues are human behavior. And in particular, for us, understanding the user experience, whether that's the ultimate beneficiary, and I'm really pleased to hear Dr. Sharma start off his talk with an analysis of the beneficiaries. Santosh before talked about reducing friction for beneficiaries. And I think that's really our focus as well, is understanding what is the user journey. But not just the beneficiaries, of course. The doctors themselves have their own behaviors, their own ways of interacting with the system, and we have to understand that. So in terms of a process, the way we've been working is really two main elements. One is to identify the barriers that the users face in that journey. And the second is around providing benefits. What are the benefits that users, these beneficiaries, appreciate, and how can we make those easily accessible? So in terms of how behavioural sciences can help, I think what you'll see on this slide is really, for all of you working in different aspects of the program, wondering how you can use this understanding of behaviour to the work that you're doing, you can see here a breakdown of sort of the key entry points. So first of all is around information provision. So can you change the information that people receive? Can you make it more attractive? But it's not just about communications, of course, changing the environment itself. And I've been lucky enough to spend some time in some of the health facilities here in India. That experience that we all talk about, what happens when you arrive at the hospital, the experience of queuing, the experience of finding the doctor, all of those things have an impact. The process design is super important too. So how do people get referred to a hospital? How do they make their way to the hospital? All of these things in the process can benefit from human behavioural understanding. Of course, incentives are a big part of what we do, even though this is a free service. So in theory, there's no one paying for this, but still we have to understand that people are not necessarily going to value their health in a rational way. We have to provide them incentives that will really kick them into action and encourage them to access the service. And then finally, of course, the legislation, the rules that govern how we work are really fundamental to success. So in BIT, basically we boil down all the interventions that we've worked on over the last 12, 15 years into 4 categories of work. So what we think is really important is to find interventions, to design interventions that adopt these principles. So it's best summed up by the acronym EAST, and that corresponds to easy, attractive, social, and timely. And I'll just put out these on the screen for your benefit. So essentially, if we, as Santosh was saying, with easy, we're trying to reduce the friction. With attractive, we're trying to motivate people to come and access. Making it social, really important, sometimes overlooked, that once we have got a critical mass and you've had so much success already, understanding how you got there and using those people who are already part of your system, how can we use them to encourage others to access it. And then finally, timely. So giving people prompts, giving people tools to plan their surgery or their consultation with a doctor is super critical. So I'll just give you two examples from work we've done in the UK, which I think might help you understand how some of these principles are applied. So in particular, we know that actually once you encourage people to make appointments, to actually go to the doctor, one of the biggest challenges is actually getting them to come for the appointment. And so we've spent a lot of time trying to understand how do you get people to avoid missing that appointment. In the UK and many other countries, when people miss appointments and they have these long waiting times for particular treatments, when people miss that appointment, it's a huge disruption. It costs the system a lot of money. So what we did is we ran a trial, and a lot of the work we do is based on randomized controlled trials, and we conducted a range of treatment options here. But the control, as you can see the message in the grey in the middle, the control message was a simple reminder that your appointment is at this time, and if you want to cancel or rearrange it, you have to go to the website to find the number. And we looked at a range of options, but in the end, the most effective sort of variation or improvement on this was a much more personalised message. One that said, we are expecting you at St. Bart's Hospital. So the specific call to you personally, the specific hospital, and we gave them a really clear piece of information. If you don't attend, it costs the government £160, and it was an immediate sort of cost and a sense of that responsibility. We also included the phone number for people, because of course it's not just about ensuring people turn up, but people have real life issues and problems that affect their attendance at these appointments. So giving them a number they can quickly call and make a change to their appointment was really critical. And in this case, we're able to reduce those missed hospital appointments by 25% on the control. And of course, not only does that save a huge amount of money in the system, but of course, it also gives the beneficiary and the doctor a much more positive experience, and obviously something that they're likely to tell other people and will improve their own outcomes. On the demand side, I've been really pleased to learn the last couple of days about how you're improving the system and developing the system. I understand that with some medical treatments in India, there are these long waiting periods, and there are some hospitals that are more burdened than others. What we're able to do in the UK with the National Health Service is actually help with the doctors and the hospitals themselves to actually identify more easily when referrals are made to which hospitals were suffering from being overburdened. And so in this case, the website, the portal where the doctors would refer people, there would be a pop-up saying that a particular hospital had, in here in red, you can see this limited capacity pop-up. So people would know that people going to make an appointment would know which hospitals, which clinics were overburdened, had the longest waiting times, and then it would give them in green up the top and a much more easily accessible list of those institutions that did have a reasonable capacity or much lower waiting times. So for us, it's not just with the beneficiaries and making that sort of appointments and access easy, but on the supply side or on the users, the doctors as users and the hospital as users, just make it really easy to find out, okay, which hospital is more easily able to service my patient. So I think in conclusion, I'd just like to say, thank you to Dr. Sharma and Dr. Rao and the team at NHA for having me here and being able to work with you on this really, phenomenal program, PMJAY. I think we've got a lot to learn in the future, and I look forward to working, hopefully, with all of you on that. So thank you for the opportunity, and all the best with your work.
Thank you, Nick. And it's a very interesting way of looking at things, and I think we should be able to find some great applications in NHA and ABDM ecosystem. So last but not the least, now we have a very special person part of this panel, Dr. Vipul Agrawal, who many of you know was till recently the Deputy CEO at NHA. And Vipul is somebody who was there, who joined I think just during pandemic, when pandemic had started, and when pandemic waned down, he left. So in that sense, I think he saw what challenges were faced by PMJAY and ABDM when it started, when the scheme is going through a difficult phase, and when the country was going through a difficult phase. So now maybe sitting few thousand kilometers away from here, what do you think could be your wish list for PMJAY for next some time? What do you think can be done to improve what has been done, and also if something new you want to suggest? Over to you, Vipul. Thank you.
Thank you very much, Dr. Jain. Good afternoon to respected seniors, esteemed panelists, and all the colleagues from NHA and all other participants who are attending this event. I would first of all like to congratulate the entire team of NHA, PMJAY and ABDM for achieving the milestones, and thank you for calling me to be a part of this event. So as Dr. Jain, you said, and Sir, Dr. R.S. Sharma, Sir, very nicely highlighted, there are lots of challenges that we observed in the implementation, both on structure as well as the functional aspects. And quite a lot of them were highlighted by Sir. So on demand side, in fact, we found the major issue with the SECC database, and with the enrichment of the database through Ujjwala, PM Awas Yojana, and also with the support of states, now we are taking up the drive to saturate the beneficiaries. We have made partners in the process in terms of our capacities to create cards on the ground by utilizing the services of government as well as private agencies. And we have more than now 10 partners to support us in that drive, and probably we have already achieved a 5 lakh card per day, and in the days to come, probably as Honorable Minister highlighted, we would be reaching to 10 to 15 lakh cards a day and would saturate before the end of this financial year. Apart from that, multiple issues in terms of technology enhancement have been taken up, and Sir has highlighted that we would be going for a health claim exchange, as well as the BIS has been revamped. In fact, lots of issues that we used to face on the demand side was because the beneficiary registration process was very cumbersome. So this has already been addressed, and in fact, in this drive, we would make full use of this technology platform that under Sir's guidance we have been able to develop. We've also roped in fact, to make, as Honorable Minister always says, that we have to make this as a Jan Andolan, because this is the scheme which has a potential to change the healthcare landscape of the country. So Ayushman Mitras have been roped in fact, several lakhs of Mitras have already been roped in to provide services in terms of referrals, in terms of ease of access to services by the beneficiary. I think all these issues, in fact, and the nudge unit, as Nick just mentioned and described, in fact, I took up a course at Harvard last year. In fact, the same model of this EAST was told to us. Probably this nudge unit is now an international phenomenon, and we would definitely like to take advantage of the experience of UK in implementing it. On the supply side, apart from HBP rationalization, as Santosh Mathew sir mentioned, in fact, we are in a big way thinking about the auto-claim adjudication and real-time claim processing. And green channel payment was made live early this year. In fact, we are paying 50% of the amount to the good hospitals right away. In the click of the button that they submit the claim, 50% of the amounts get credited back to the hospital. So this has been something which would give ease of doing business confidence to our partners. And on overall utilization front, in fact, the most important aspect that we used to face was that public hospitals were not participating to the extent. Hardly 30 to 40% of the total scheme utilization comes through public hospitals, and 90% of them are probably actively not giving us good numbers. So Beneficiary Facilitation Agency was also started under the guidance of CO NHA, and it is yielding very, very good results. In fact, in Madhya Pradesh, almost 300% increase in the claims from public hospitals has started coming because of this process. And apart from this, e-rupee to improve the processes has also been implemented into the system, so that the problem that our beneficiaries used to face in terms of taking services like procuring medicines or diagnostic services where they had to spend out of the pocket despite the fact that it is a part of the scheme. So through this e-rupee, that issue also has been addressed, and it has been launched on a pilot basis already in 2 states, and we are scaling it up to the entire country. I feel that in terms of the wish list, the first and the foremost challenges or the issues that we need to take up in the immediate future is first, Aapke Dwar Ayushman should saturate the 100% beneficiaries, and we should at least be able to provide services to all the beneficiaries who are entitled for these services. And as sir mentioned, that awareness and beneficiary empowerment are the most critical aspects. We have suffered in terms of our utilization figures because of the low awareness amongst our beneficiaries and at all levels. In fact, the awareness among the hospitals about the scheme information, what scheme changes we are incorporating, like the HPP advancements and upgradation, that also does not probably go down to the grassroots level. So I think some drive on the lines of Swachh Bharat or some campaign needs to be taken up, which makes it a scheme which everybody knows about, all the beneficiaries, all the hospitals, even the capacity building aspect of our stakeholders needs to be addressed. And in fact, in terms of the ground level implementation, I feel another challenge that we need to address in the immediate near future is the aspect of strengthening our district units. So unlike the National Health Mission, which has a very, very strong implementation machinery on the ground, where our scheme suffers is that ground level coordination amongst the healthcare functionaries and PMJAY support to PMJAY to be provided by the healthcare infrastructure, that also needs to be strengthened, and we need to have a dedicated human resource capital available on the ground to work for us. So that is something that we need to work on in the immediate near future. On the long-term aspect, I feel as the scheme was envisaged to be the driver for the universal health coverage in the country, when national health policy was implemented, it was formulated that time, PMJY was conceived to be the scheme to achieve universal health coverage. I think we are far from there. In fact, we need to now utilize all the 4 arms of Ayushman. In fact, the most important would be Ayushman Bharat Health and Wellness Centers and the ABDM as a force multiplier to ensure that we get the forward and backward linkages that would ultimately, unless we link it with the primary healthcare arm, PMJY would never be able to achieve its true potential. So the universalization of health coverage would come only once all 4 arms of Ayushman work together, and ABDM now, as I mentioned, is a force multiplier that we should make full use of. Apart from that, convergence of healthcare schemes in the government, on the government front, apart from PMJY and 4 Ayushman Bharat pillars supporting it, we need to quickly achieve the convergence, not merger. Probably the first speaker talked about the merger of schemes. We do not intend to merge the schemes. The scheme should remain and retain their originality, but we should have the convergence of the scheme so that we have a unified scheme database available with us. We have uniform healthcare benefit packages. The rates might be different, but there should be some uniform payment mechanisms, so that we need to work on those. And last but not the least, to rope in the rest of the beneficiaries or the population of the country, which would be requiring some sort of subsidization of healthcare services, we would require this missing middle pilot to be taken up very soon, as early as possible. And in the medium to long term, this middle class population, middle 20 to 30% population also needs to be provided a benefit of low cost insurance. On the provider payment reforms, I feel that DRGs, the pilot has already been initiated at the level of NHA with the support of international organizations and partners. So this DRG would also make a very big change in terms of our provider confidence, and also to ensure that the payment is as per the disease condition of the patient, rather than a standard unified payment mechanism that we have in place as of now. And also on the strategic purchasing and collective bargaining front, we need to achieve some progress, because the providers are not being able to gain from the collective strength that we have as a single scheme. So if we could institutionalize some mechanisms wherein we can provide the support in terms of procurement, low-cost procurement to our providers of the raw material and services, I think that would give them the viability and reduce the cost in the long run. So ultimately, the scheme objective of providing accessible, affordable, equitable, and high-quality value-based care is something that we should try and achieve. Thank you very much.
Thank you. Thank you, Dr. Vipul Agrawal. And I think there were so many issues which you have highlighted, and I think many of them, as you said, work is going on, and many of them I think we need to start thinking a bit more on those lines. So, we got very rich inputs from everybody, and and we need to plan and we need to prepare better. And that's just reminded me, I'll tell you something in 30 seconds. So there was a very famous paratrooper, people who jump from the flight with the parachute. He used to teach students, and he was very good with that. So when he was taking a class, at the last day of the class, he asked the class, do you have any question? So one student asked, sir, what made you jump for the first time? Why did you decide to become a paratrooper? How did you jump for the first time? He said, there are 10,000 feet, dead pilot and 2 dead engines. So I had to jump. So we should not be that paratrooper. We should plan our jump. We should not be forced to jump. And that's where I think the strategic thinking and planning will come. And for that, I hand over to Dr. Paul, please to guide us. Thank you, sir.
Thank you, Nishant. Thank you. In ideal circumstances, we should be discussing a little more because there is, the panel has provided questions, has provided answers, but then the questions that are left hanging and unresolved need more discussion even as the journey for UHC continues. We must realize that the goal of universal health coverage is achieved over a period of time. We do hope this period of time for India will be shorter than that experience by other nations, because we can learn from them, and we are learning within our own country in different states, and each state in some ways is a unit and a country by itself. Having said that, my takeaways from this discussion are following. Firstly, I think time has come for PMJAY to track quality of care, and it is doable. I referred to this in my intervention yesterday also, that we are measuring the patient feedback, and I think based on patient feedback, what needs to be done is already happening, more can happen. But in terms of clinical quality of care, the outcomes, the services, the processes, the timeliness, the SDGs, this point that has been made in this panel, I think is worth considering very seriously. Nishant, you may recall that in fact in our original documents we had talked about state level, what we tried to call at that time audit groups, which will keep a watch on the clinical pathways and clinical decision making and so on. So maybe we pick up from today's discussion, create pathways on, to begin with perhaps only looking at audit as an audit process rather than naming and shaming process, because that's how audit systems work in hospitals. We look at an adverse event, say a death, and see what we could have done better. So maybe a beginning can be made by that kind of an approach, and as we mature, other aspects such as rewarding and maybe naming and shaming could come at some point in time. But there is a line beyond which there is an element of negligence. That's not acceptable. If today, cesarean sections are increasingly becoming a norm, really not acceptable. So we have to really have a pushback, but I think that's my first takeaway. The time has come that we start monitoring systematically quality of care, and for which, of course, we need a deeper dive to understand how to go about doing it. But this is one takeaway in the fourth, the Arogya Manthan that we have. Second, I think from the presentation of Nick, two aspects came up. One is the behavior change aspect, but I saw something which was more important underlying this, the use of data. The use of data and then responding to this relatively quickly is very fundamental. We are collecting so much of information. I think clearly we need two pathways of those analyses, those that are academic, those that are setting the policy for future, those that are looking at demographics, outcomes, and so on, and health. That's one part. But then there are aspects which give us insights into improving our processes for which the decisions are decentralized. They can be taken really in real time. So use of data coupled with that, a behavioral change approach is my second takeaway. My third takeaway comes from Dr. Kwan's presentation, where, in fact, that point has been highlighted by you. I'm just adding a voice to this. Pooling, convergence of schemes is always considered a best practice, which has been, in literature and worldwide thinking, is truly the way forward. I think we have done very well so far in a complex scenario that prevails in India with different such schemes. Above all, PMJAY has been the mother scheme for the state level scheme. That itself is a huge achievement, which we should really celebrate. But on top of which, to have ESI on board, have other schemes on board, is really a way forward. ECHS scheme on board in some ways. I think we're doing well, and we should continue to be alert to capture these opportunities and bring it all together. The third takeaway is in regard to the fact that we do need to be in a situation where the beneficiary is not to be, is to become more visible. Our database constraints have been to some extent addressed, but we need to go forward. This remains as a challenge. Your thoughts in this, how to smoothen a process where we don't end up with 20 crore or 25 crore cards only in terms of beneficiaries identified, but really go up to $500 million, which was the import of the scheme, has come up as a theme that we continue to address our attention, and we must find a way. On the next issue of missing middle, I think the debate must go on. We still, as my distinguished colleague Dr. Sharma said, we still have not really reached a conclusion. But one obvious aspect is, or one obvious way is, can we have this population of these families pay a certain amount upfront, which can sustain the PMJAY system, and then enter the PMJAY scheme, even though I'm not in those 2 quintiles that we are truly covering. Is that an easy way? Will it load the system, overload the system? What are the problems that could come up if we take this approach, or is it doable? I think that's another true, point on table right now that we can start discussing even more vigorously. This is a question that only time will answer, because we have been addressing it. We really not found a true solution where we are all comfortable. 2 points I thought need emphasis. One, timely payment. This has been mentioned. We have done well, but can we reach, the optimum stage where there is a satisfaction on the part of the provider family of hospitals that they do get the money on time, and whatever we can do to ensure in trust, as was stated by one of the panelists, should be done. We didn't discuss bulk purchase to make the whole exercise more affordable. Strategic purchase, I think again the time has come that for certain commodities that are used in the PMJAY system service delivery, we should be in a position to invoke strategic purchase. It will reduce the cost, increase affordability, and bring in the overall, equity in the healthcare purchase, shall we say. But above all, the last point that I wish to make is that we must continue to think about ways and means of empowering the beneficiary. We heard from an eminent speaker today that, navigating the processes still looks fuzzy. So we must continue to make sure that the ease of business for PMJAY program by the beneficiaries remains on our agenda. And on this, data, information, feedback, going to the ground, learning from, hearing the beneficiaries would be very, very useful. So I think the beneficiary is at the heart of this program. And as the Honorable Health Minister said yesterday, that we must never forget that all this exercise is for the beneficiary and empowering the beneficiary, making the life easy for the beneficiary to access services of a high quality, satisfying the beneficiary. It remains our true goal of this wonderful program, wonderful mission, which, as we have seen, is maturing. And today's milestone of 4 years is very heartening. As we move forward, we would join hands, we join our intellect to find solutions to the problems which still beset this. And some of those suggestions, some of the suggestions that have come up today would be very useful for further introspection by the government. Thank you very much.
Thank you, Dr. Paul, and I think very nicely you summarized, and I still remember that we used to talk, or we still talk about the continuum of care, that how do we also somehow bring primary care, if not necessarily under explicit package, but how do we ensure that health and wellness center and PMJAY are linked? That was the original vision under which Ayushman Bharat umbrella was being thought of, which you were one of the main architects. So I think that we need to seriously think on those lines also, that how do we do that? And in addition to anyway what all you have mentioned, these are very important points. So we would have really loved to take question answer from the audience. That's what we would have preferred, but unfortunately not right now, but we have all the experts available here. So you can always go to them and ask some questions, and we will come out with it. So with this, I'd like to thank all the panelists who are here or online. Thank you a lot. Thanks a lot for very enriching discussion, very interesting insights which have come. I hope it will help NHA to move further. And thanks a lot, and thanks to a very patient and wonderful audience. Thank you very much.
Thank you everyone for such an engaging discussion. While we're concluding our sessions for PMJAY here, we have a lot to reflect on and a lot to look forward for the PMJAY scheme going forward. I would now request CEO Sir Dr. R.S. Sharma to present the mementos as a vote of thanks to our panelists, starting with Chairperson Dr. V.K. Paul. Dr. Sunman Kwon. Dr. Nick Goodwin. And Dr. Nishant Jain. Thank you all for being a wonderful audience.